thank you very much. I'm delighted to be here today. And obviously this study day is based on allergies. And you might think, well, what on earth is somebody here going to be talking about eczema for? Well, the reason is eczema is associated with allergies, and everybody seems to think, well, they've got eczema, it's because of an allergy. There is a link. Most children who've got allergies have got eczema. Most children who've got eczema don't have food allergies. So that's what I'm going to talk about today, is the role of eczema within allergies and the importance of the treatments of controlling the eczema. We've heard about how if you've got good asthma control, then you've got a better prognosis if you've got allergies. It's a similar sort of thing with eczema. So I'm going to just go over, there's a number of different types of eczema, and I'm going to run through them quickly today. So some of them are called endogenous eczemas, they're from internal causes, and then there's a couple from external causes. So seborrheic eczema, we see this in young males and females and in teenagers. We also see them in young babies with the cradle cap, and then often when somebody gets older with that sort of inflammation around the sides of the nostrils. You've got discoid eczema. Now I see discoid eczema surprisingly in my children's clinics, and it's often confused with fungal infections and with psoriasis, because when we think of children's eczema, we think of dry skin and then inflammation in the flexures. Discoid eczema, you often get a normal background texture to the skin and then these circular lesions. And this is a particularly stubborn type of eczema. It's more challenging to treat. It's associated with a high colonization of bacteria on the skin. And it often leaves sort of residual areas of colouring afterwards, what we call post-inflammatory hyperpigmentation, for quite a while afterwards. Now, I am a children's nurse. I only work with children. So this is a type of eczema that I don't tend to see, but I know that my adult colleagues who might get called down onto the care of the elderly wards come across this. And I certainly know that a lot of people, when they've been on holiday and they come back after a holiday, and if they've got a little bit of a tan, the skin then becomes dry and you get this craquelé appearance to the skin. So this is an asteatotic eczema. We often see it in the care of the elderly wards because they're often bed bathed or bathed out on a daily basis and with soaps, which will damage the barrier function of the skin. And then you've got Pomfrey's eczema, and it's an intensely itchy type of eczema that often affects the hands. It's described as little sort of sago grain type changes on the sides of the fingers. Again, very difficult to treat, very, very itchy, needs a lot of high steroids. Varicose eczema, see around patients who've got poor circulation, varicose veins. And then we've got atopic eczema. So this is what I specialise in. This is what I do day in, day out. I've been working in children's dermatology, been nursing about 39 years next month, but I've been working in children's dermatology for about 25 years. And as Helen said, when we started, or when I started, we were saying about maybe 1 in 15, 1 in 20 children had eczema. We're now saying 1 in 5 children have got atopic eczema. So it's a huge increase and it's more challenging. And I certainly know within primary care, this is one of the biggest problems that GPs will see with the inflammatory conditions within children. I know I've got school nurses and health visitors constantly on the phone because it is an increasing problem. And it's unfortunately, because it's often difficult to source the correct information about management, there's a lot of conflicting information on the internet, which can be quite challenging. It's unregulated and it causes a huge amount of concerns for parents. So those are what we call the endogenous eczemas. Those are from internal causes. And then we've got exogenous eczema from external causes. Now, over the COVID pandemic, I'm sure that we've all had a little bit of primary irritant contact dermatitis from having to use hand gels constantly, washing hands constantly. A couple of years ago, I was having a number of usually young girls 7, 8, 9-year-olds referred in with a sudden development of hand eczema just on the side, on the palms of their hands. And I got to the stage where I was, do you like playing with slime? And it's, oh yeah, I love it, we have slime parties. If any of you have ever come across the craze a few years ago of slime, where children would make their own slime. Slime contains every potential irritant, I think, from shaving foam, borax, contact lens solution, air freshener, you name it. And it's in slime. And we were having awful problems with children presenting with irritant hand eczema. And then you've also got contact dermatitis. So this is where you get your allergies to chemicals. This is what we do patch testing for. The most common of the allergens is nickel, and hence the pictures on the left. You often see an area of inflammation around the umbilicus if people are wearing belts. I think I have 2 children, well, they're now in university age, and I was always the very cruel mum who, when we were on holiday, I would never let them have these henna tattoos, the black henna tattoos. Pure henna, brown henna, is very low allergenic. When you see on holidays that black temporary tattoos, that's actually got hair dye in it. PPD is one of our most common allergens. So if you've had the temporary tattoos, the henna tattoos, you're having your exposure to your PPD, which is then in hair dye. And because a lot of the allergens develop through contact through the barrier of the skin, we started seeing more and more patients coming in with allergic reactions to their hair dye. So as a mother, I said, no, you're not having temporary tattoos, because I'm sure that as you get older and of a certain age, being able to use hair dyes becomes increasingly important. And if you've had a lot of your temporary tattoos in younger years, you're increasing your risk of having reactions, and that's what the lady on the top has had. I do a lot of lecturing about safeguarding within children's dermatology. That's my other particular interest. And I often have this picture that was given to me. And here the patient turned out to be allergic to the cleaning that was used on the toilet seat. So odd patterns of eczema. We do patch testing. I've just referred a child on for patch testing because she has developed eczema and was referred to me with eczema just on the tips of her fingers, which is an unusual presentation. And it's been going on for about 2.5 years. So hadn't had it anywhere else, never had ordinary eczema as a child. And I thought, well, this seems a strange pattern. So before I sent her on for patch testing, I was asking, has she had any new hobbies? And she discovered cooking. In lockdown, she enjoyed cooking. So the clue was straight away that eczema just on the tip of these 3 fingers, and she was right-handed. So I've referred her for patch testing because I think she's got an allergic reaction to garlic. Because if you cut garlic, you hold it, the clove, in those 3 fingers and chop with your dominant hand. So patch testing, contact dermatitis, it's quite fun because you're trying to work out what they're likely to be allergic to. I remember sending one young child over for patch testing because he just had eczema on the lower part of his legs. And he was about 4, 5 when it started, and he was about 7 when he came to me. He lived in Wellington boots, so he was allergic to the lining. So patch testing is the type of allergy testing that we do with eczema a lot for odd presentations. But this is what I do day in, day out. Atopic eczema. So as I said, it's increasing in incidence. About 1 in 5 children, it runs in families, it's associated with the atopic conditions, the asthma and the hay fever. Most children will outgrow it within about the first 7 years of their life, but a number of children will go on to have it through their teenage years and on into adulthood. But a lot of my children will have it as young little ones. And it often appears round about 3, 4, 5 months of age. And I think this is where in the early stages, because that's often a time where people will start weaning, that's often then causes confusion that actually is the eczema down to a a milk allergy because they may have come off breastfeeding and started having bottles to top them up, or it might be that they're having more foods in their diet. But it's often a little bit coincidental because you've got the pH of the skin changes, and that influences the growth of the natural moisturizing factor. So eczema starts in a lot of children at round about 4 or 5 months of age. And I often teach the health visitors that if you see a little split at the base of the earlobe, that's one of the first signs of atopy. There's a high chance that that child's going to go on to develop eczema over the next few months. So I say to health visitors, when you're doing your baby clinics, when you're weighing children, if you see that little split there, bear in mind that child's likely to develop eczema. So have a chat about, are they over bathing? Make sure they're not using the highly irritant bathing products that make a baby smell like babies are supposed to. Keep away of that. And we often find with younger children and with babies that the cheeks are often initially affected. The stratum corneum, the outer layer of the skin, is so thin on the cheeks in babies that it virtually just falls apart so easily. So, how do you recognise eczema? Well, a lot of us will automatically have dealings with eczema and will recognise it straight away. But the big thing I say is it has to be itchy. If it's not itchy, it's not going to be eczema. You need to rethink your diagnosis. And then we look for about 2 or 3 other signs. The dryness of the skin, these itchy little vesicles, weeping, erythema, redness, particularly in the flexures, inside the wrists and inside the elbows, scratching, crusting of the skin, white dermographism on the bottom picture, this sort of skin writing. They're all some of the signs that we look for in diagnosing eczema. And then with chronic eczema, again, it has to be itchy. But then we're looking at slightly different changes. So in the middle, you've got what we call lichenification, these sort of thickened areas of the skin that often comes from months or even years of scratching. Denny Morgan folds, that's that extra little crease that you often see underneath the eye. The skin around the eye is at its thinnest. So because when you've got eczema, you've got a little bit of edema in the skin, there's no leeway in that fragile skin that is so thin around the skin. So it almost like folds over on itself. So that makes it quite easy to straight away spot a child who's got some eczema because you'll see these Denny Morgan folds. And hair loss, now that sounds quite dramatic, but it's eyebrows in particular. Because if you've got a child who's got eczema, quite often what they'll do is they'll just rub and rub and rub at their eyes, and they scratch away the actual outside of the eyebrows. So often what will happen is a child will come and maybe their eyebrows stop here because they've scratched them away. So I set them a little bit of a challenge, and I get a pencil, and if you put a pencil from the outside of a child's nostril, tip of the eye, corner of the eye, where it reaches about here, that's where their eyebrows are supposed to grow to. So sometimes I've had children come back a few months later and they grab my pencil and they like to show me they've grown their eyebrows back, and that's an indication for them as well as me that we're beginning to get that eczema under control. So what causes eczema? It's not down to an allergy for the majority of cases of eczema, particularly in children. It starts off as a genetic defect of the barrier function of the skin. The skin just isn't formed properly. And then we've got trigger factors. So stress. I don't take off the week before Christmas because all of the children under the age of about 6 or 7, they're so excited and stress is the flip side of excitement. So, of course, somebody in a big red suit's going to be coming along. So they're so excited. They've had all of their parties. That will cause a flare of their eczema. But also physical stress. They all seem to flare up about a week after they've had their vaccines. So we say, actually, yes, they must have their vaccines, but don't cut down the steroids at that point. In fact, be prepared to add in steroids because the skin is likely to flare, because any type of stress, emotional or physical, is likely to cause a flare. The dry skin, that in itself is the big problem. So this is why, and I'll be looking at the basic treatments, the dry skin, the moisturizing is so important. Then you've got your irritants, and you've got your allergens. They all flare up at season change, and I live in dread of the pollens. Everybody's saying, oh, isn't it beautiful blossom? And I'm thinking, no, I'm going to be picking up pieces next week. Allergen exposures, also things like, you know, cats, house dust mites, and then Staph aureus. That's a big, big issue with what drives a flare of eczema. But in the centre of that, you've got this genetic defect of the skin. And then you've got these environmental things, and in the middle of that, they come together, and that's where you get your eczema. So, a filaggrin mutation. Now then, the skin, I'll be looking basically very simply about how the skin is made up. But when I see a child with eczema, I always like to look at their hands. And quite often, if any of you are parents who've got children with eczema, you might well say, oh, their hands always look like little old man's hands. Always got lots and lots of little lines on them. So what we call hyperlinearity, these exaggerated lines on the palm of the hand and also on the soles of the feet, that indicates to me a filaggrin mutation, a genetic component to the defect of the skin. And I know those children, they're going to be a little bit more challenging. They've got an increased risk of having problems with the cold sore virus. So this infection on the skin. So quite often, if I've got a child who's got a filaggrin mutation and difficult eczema, and I'm going to be looking at some of the immunosuppressants, I will automatically, if they've had any contact or any type of a cold sore, I'll be putting them onto acyclovir for months, just to make sure we don't get an outbreak. And unfortunately, these type of children are more likely, theoretically, to have problems if they're cats. So I don't say shoot the cat, but I do say, please don't buy any new cats. Please don't replace any cat when anything naturally happens. And please make sure the cat does not go into the child's bedroom and sleep on the bed. So we look at the cross-section of the skin. Towards the left, you've got normal skin. And towards the right, you've got eczematous skin. And what you can see is the top part of the skin, it doesn't fit together properly. You've got that inflammation, you've got that vesicles, and you've got this stratum corneum where it doesn't fit together properly. And that's where the problem is with the eczema, is this defect of the barrier function of the skin. So what I say to parents when I'm explaining how eczema works is your skin is made up like a brick wall, and in every cell is the natural moisture, and your skin makes a protein a little bit like that orangey line that connects everything, a little bit like cement in a brick wall. That's how your skin is, and in every cell is the natural moisture. Now when you've got eczema, your skin starts off by not making enough of this cement, not making enough of the protein. So your skin is like a brick wall that hasn't got enough cement. So first of all, the moisture evaporates out too quickly. You get increased transepidermal water loss. So you get the skin feeling dry. And that's the first thing that you do. So what happens then is that the barrier doesn't work quite as well. Now, on the top of everybody's skin, you've got lots of different types of bacteria. Supposed to be there, that's normal. Nothing to do with hygiene, that's just what it is. When you've got eczema, again, nothing to do with hygiene, you get less different types of bacteria and more of one particular sort. And if the barrier doesn't work properly, that bacteria can penetrate through the barrier function of the skin that's not working. And your skin, within the skin, you set up an exaggerated immunological response. And that's what eczema is. It's not just one component. You've got this inability to keep the moisture in the skin. You've got the fact that the barrier doesn't work properly. You've got this exaggerated immune response. And in response to bacteria penetrating and other irritants, and that can even include food proteins, and a lot of children will develop their food allergies to things like the peanuts and things like that through that protein entering through the barrier function of the skin, because the skin thinks, don't know what that is that's got through there, that's not supposed to be there, and it's got an oversensitive immunological response. So it will set up an inflammatory response, and the skin will get red and itchy and angry. And that's when we use the steroids to settle down that response. But far more important is the moisturizers. So the moisturizers work by helping to trap moisture back in the skin to help restore the barrier function of the skin. So although we use steroids, and everybody gets very twitched about using steroids, and I'll look into that in a moment, because there's an awful lot of anxiety, and the biggest problem that I see when children get referred in to me for eczema management is actually underusage of the steroids. But although we taper out the steroids, the most important part of eczema management is the moisturizer. That's your preventative thing. And I say the more you can moisturize the skin frequently, regularly, then the less you're going to have any other problems. So a typical routine for eczema management would be in the morning, top and tail, wash, whatever, moisturize, moisturize, moisturize. So moisturize at breakfast time or moisturize before they go to school. Now I accept that a lot of my children are going to be in school, so that's not really that easy, but certainly as soon as they come in from school, uniform off, moisturizer on. And you know, if a child is at home with the parents, I say, well, every time you change the nappy, put on a bit of moisturizer. That is the most important thing that you can do. Then in the evening, you bath them. We do bath our children with eczema, but we don't use those bubbly cosmetic-y products, even the ones that over the last few years have been very cleverly marketed. They are not going to be helpful. But we do bath, and then that's when you put the steroid on after the bath to any patches of eczema. You don't put your moisturizer on straight away. You let it get absorbed by the skin for about half an hour, and then you put on the moisturizer. And as time goes on, we slowly reduce out the steroids, but we keep on with the moisturizer. And I say to parents, it's a little bit like the more you teach your child to clean the teeth, the more you clean your teeth, the less you're going to need to have fill-ins. The more you moisturize, the less you're going to need to have the steroids and all of the other stuff. So let's look at that awful swear word of steroids. Well, steroids come in 4 main potencies. Never look at the percentages because they're very, very confusing because they're not interchangeable. So you can get hydrocortisone, you can get it in 0.1%, 0.5%, 1%, 2.5%, and they're all mild steroids. Hydrocortisone is so gentle, you could almost bath a child in it and I wouldn't bat an eyelid. Very, very difficult to cause any damage with hydrocortisone, okay? Then you get, and the biggest problems that I see where parents say, oh, it's just not working, is actually they're not being given anywhere near enough. Then you've got your middle section that hasn't come out that well, but you've got Humavate. Now, Humavate it's a comparatively gentle steroid. The consultant that I work with, he would like to see Humavate come in a 500-gram pump dispenser so that people realize, don't be frightened of them. All of the steroids are drugs. You respect drugs, and they've all got side effects if you don't use them properly, but don't be frightened of them. Use them properly, and for a lot of children, they work phenomenally well, and we don't have the problems that people are frightened of. Then you've got your potent steroids, Cutivate, Betnovate, Elacon. Occasionally then, there are Dermavate, super potent steroids. We don't use those in children's eczema management. We go to other things. But the biggest problem that I see is actually so much anxiety about steroids that people are not using anywhere near enough. So when you're using your steroid quantities, I work with what we call fingertip units. So a single stripe of steroid that goes from the crease to the very tip, to where your nail is, that amount of steroid will cover that much eczema. 1 fingertip unit, 2 hands worth of skin. It's as simple as that. So the steroid will settle down the eczema. We prefer steroids generally to be in the ointment form, the greasy base. It works so much better. Now, 1 stripe of steroid from there to there. and will cover that much eczema. And it goes on after you've bathed this child, where you've washed off all of the other stuff that's been used through the day, and where the skin is nicely moisturized from the water, from the bath oils that trap it in. That's when you put your steroid on. And what you do is you smooth it all over. You don't frantically rub it in. You smooth the steroid over the eczema so that you can see it glistening. And you let it work for about half an hour. And you put on your moisturizer. Now, steroids work from the top down. So you don't stop the steroid after 5 days when the visible eczema looks better. You've got to get to that deeper invisible eczema. In the same way as if a child's got a ear infection and is given 7 days of augmentin or amoxil, you don't stop it after a day because their temperature's settled and their ears stopped hurting, because 3 days later they're going to be poorly again and you start all over again. For the majority of a course of antibiotics, your child's back to normal. It's the same with eczema. You don't stop the steroid when the visible inflammation looks better. You carry it on until you're reaching that deeper inflammation. And that means about 3 weeks. And you don't suddenly stop it, you slowly taper it out. Partly because if you suddenly stop the steroids, you'll get a rebound flare-up. If you start stopping the steroid, and let's say that your little one has got a cold or is cutting back teeth, that stress is going to drive the eczema. So by slowly tapering down the steroids, you can pull back control quickly when needs be. So we use the steroids, as I say, about 3 weeks initially. So the big problem that I see is too weak a steroid being used. I get some children coming to me, and they might have been given 15 grams of 0.5% hydrocortisone. That's not going to do anything. That's pointless, waste of a prescription, because I'm a little bit bolshy like that. Stop this too quickly. You don't just want visible healing, you need to get to the invisible healing. If you have got a child, or if you've got eczema, let's say you've got bad, bright red, awful patches there, and then low-grade eczema on the rest of the arm, or for some children, if they've just got it really bad, but then low-grade elsewhere, you don't just put the steroid to the worst bits of eczema. Because if you do that, the not-so-bad bits of eczema will release chemicals that will flare it up, and then you just go chasing eczema around the body. So quite often, if I've got a child who maybe's got it really bad on the arms and the legs, and then not so bad on the trunk, but you know there's mild eczema going on, I say, okay, top to toe, put the steroid on all over every evening, except under the nappy. That's a bit of a different area. For about 3 weeks, it's not going to damage the skin. And in fact, we've just brought in a protocol in my trust where we actually say that before a referral can come into us in secondary care, the child has got to have had Umivate all over for 3 weeks, and we give them a guidance of how much they should be given and the amount of moisturizer, and they have to have done that before the GP is allowed to settle it, to refer them in. Because for the vast majority of children, if they just have a couple of weeks of concerted steroid properly all over, then that solves it. And then you keep on with the moisturizers. A lot of people say, oh, don't use it on broken skin because that's going to be too harmful. That broken, excoriated eczema, that's the most active eczema. That needs the steroid. So yes, you do put your steroids onto the broken eczema. Is that making sense so far? Okay, but then the moisturizers are the most important part. And as I say, don't pussyfoot around with a very mild steroid. Go for something that's got a bit of oomph to it, because you've got to get the skin out of trouble. Because the more that you can get the skin out of trouble and settle the eczema, get it under control, the less you're going to have problems in the long term, and the less chance of you developing food allergies, which is so important because you've got to get that barrier function of the skin restored as quickly as possible. So the moisturisers, though, that's a bit like cleaning the teeth, done every single day as often as you can. Let's say you've got a 6-year-old child. How long do you reckon that big tub of moisturiser should last? Spot on, 2 weeks. Yeah, so 500 grams of moisturiser every 2 weeks for an infant and a younger child, a tall teenager, adult, 500 grams a week. And that's not just while they've got visible eczema, that's for the foreseeable future. And the more you can moisturise, the less you're going to have other problems. And we use bath oils, we use soap substitutes. I know there was a bit of a research project a number of years ago that said, don't bother using bath oils, you're just pouring it down the sink. I ignored that. I still give bath oils. I spoke to the nurse who'd been involved in the study and she said, I still give them. They work. It's another way of getting the moisturiser. And in fact, we've now gone back full circle and they're now saying, yes, actually, use a bath oil. So the moisturisers, they increase the efficiency of the epidermis, they restore the barrier function of the skin, they enhance the absorption of the steroids, which means that we can then get away with slightly milder steroid, not too mild a steroid, but if you're using your steroids on really well moisturised skin, you can often get away with Humavate, whereas if you're not using enough moisturiser, you might have to use something stronger like Betnovate that's got more side effects. So the moisturiser cannot be overestimated, the importance of moisturisers. We do bath children every day. What we don't do is add in those nice cosmetically purchasable bath products. You want something that's just going to be a nice oily product. We use a lot of soap substitutes. Most of your moisturisers can be used as soap substitutes. If parents want to go for the natural approach, a cupful of porridge oats. Put them in a foot of a pair of tights or a muslin square, run the hot water through it, and that will release this beautiful oil that is really good for eczema. A child's going to smell of porridge, but there's worse problems in life. So it's worth knowing that if you've got a child who has got dry, low-grade eczema, it is completely normal for the skin to go bright red when you put the moisturiser on. Don't panic about it. They're not allergic to it. That's just what you expect to happen. And I get some children coming in and the parents will say, they're allergic to every moisturiser. Okay, what happens? Well, they scream that it stings and the skin goes bright red. Yeah, that's normal. It's normal for, if you've got skin that is very, very pale, dry, and you've got that white fine scale, that white dryness is hiding the underlying red eczema. And I say, as soon as you put your moisturiser on, it's only going to show you actually how bad the eczema is. So it's normal for it to go red, but if no one's expecting it, you're naturally going to think, oh, they're allergic to this one. The other thing is on dry, broken skin, anything that is white, a cream with a pump dispenser, it's got water as its base, it therefore needs a preservative. That combination will sting on dry, broken skin. It doesn't mean the child's allergic to it, it's just what is normal. So I always give an ointment-based moisturiser, Vaseline if needs be, for the first couple of weeks or even few days, and then once the steroid has started to kick in, then we switch to the cosmetically more acceptable products if they want. If they're happy with the ointments, and I've got a number of children who just like the nice, thick, greasy moisturisers, fine. The best moisturiser is the one that the child likes, the one that the parent likes. But if that means that I'm giving 3 different bases, a lotion for before school, a cream for after school, and an ointment for bedtime, so be it. But what we do then is we slowly taper out the steroids and we keep on with the moisturisers. That is the most important part of eczema management. We can't cure eczema, but we want, I hate the phrase flatten out the curve after COVID, but that's basically what we're trying to do. We use the steroids to try to flatten out the curve. And if that means that over the winter period, I'm advising put a steroid on all over twice a week, regardless, to keep on top of it, so be it. but we always moisturise. We don't cut down the moisturisers. Our ultimate aim is that eczema is controlled with the moisturisers. And then we do maintenance, so steroid twice a week. If I think a child's using a little bit too much steroid, I might bring in an immunomodulator, Protopic. Protopic, Elidel, they're not very good for getting the skin out of trouble, but they're quite good for keeping the skin out of trouble. And we've now found out they're an awful lot safer than we first thought. So what's important is we're not looking for a cure, but we're looking for control. And the better control that we have of a child's eczema, the less they're going to develop their allergies at a later stage. I work very closely with my allergy consultants because we all know that it's important that you've got your skin control right. We also know that there's such a thing as an atopic march. So eczema tends to peak around about a year or so. Gastrointestinal, your food allergies, your cow's milk is often younger. But what we know is that as eczema peters out, asthma becomes more of a problem, and then at a later stage, just when you think you're out of this, you then get your hay fevers. But there's more and more research going on into food allergies, and more we're beginning to think, actually, do some of those allergies develop through the barrier function of the skin, which is why the moisturisers and eczema management to get that barrier working properly is becoming more and more important. And as I said, hopefully we can reduce the risk of other allergies. Have to be aware of bacterial colonization. The more inflamed and broken and the skin is, the more you're going to have bacteria on the skin. Sometimes we add in antibiotics. Sometimes now we're beginning to use bleach baths. That doesn't mean domestos, it means Milton. And we are finding for some children that if we use Milton in the bath on a regular basis, we're normalising that amount of the overgrowth of bacteria on the skin, which is one of the things that can drive eczema and cause flare-ups. When I do, just something for you to be aware of, if you've got toddlers, if they've got eczema around this area, around the muzzle area, it's the one time that I do start saying, ooh, do they have a lot of spaghetti bolognese, tomato sauces, pasta shapes in tomato sauce? Because the tomato sauce is directly on the skin, bearing in mind the skin on the child's face is very thin and fragile, an irritant reaction you can get from irritant foods. So as I say, tomato sauces, so spaghetti hoops, pasta shapes, spaghetti bolognese, citrus fruits, the juice is getting directly on. And the worst thing that parents can then do is grab your nearest baby wipe, even water wipes, and wipe it off, because you don't want to do that. What you want to do is actually put a nice thick greasy emollient on beforehand so that the foods don't get directly onto the child's skin, and then wipe it off with a flannel with more emollient. One thing that we do know is that it's not my role to look at a child's diet. That's why I have my colleagues. But if I do see a child who's got splits in the corner of the mouth, we will think about what we call angular cheilitis. We will think about low iron stores, because the sign for that is angular cheilitis, and that in itself makes eczema more challenging. So that is my whistle-stop tour of eczema management. And all I'll say is, don't forget the moisturisers. They are the key to it all. Thank you very much.
Thank you.
There's a lot of confusion about that. It's not the end of the world either way. So the reason in my trust that we say steroid first, your steroid has to go on to moisturise skin. So if you're moisturising at breakfast time, lunchtime, tea time, and then you're using a bath oil, you've got moisturised skin, okay? We always say steroid first. I guess because I first learnt about eczema by being shipped up, kicking and screaming all of the way up to Great Ormond Street for 2 weeks to learn from John Harper and Rosie Turnbull, who were big names in eczema. And they say steroids first after a bath. And I thought, well, if it's good enough for Great Ormond Street, it's good enough for me. The important thing is if you're using an ointment-based emollient, let's say, and you put it onto the child's skin, and you've got that nice thick layer of moisturiser, and then you go to put your steroid on top half an hour later, you're not quite sure how much is going to be absorbed. Whereas if you put your steroid on when they've got out of the bath on that nicely hydrated skin, feels a little bit tacky and is ready to suck in whatever you put on it, you're going to get good absorbency of that steroid. The half an hour thing is the important, but that's the important thing. But I found for some children, just tweaking around when the steroid goes on, that does make a bit of a difference. If you're bath them every day. Bath every day, but 15 minutes, warm water, and nothing that is conventional, so no ordinary soaps or things like that. And we use soap substitutes. We use all of the moisturisers will be used as cleansers. And I say to parents, in the same way as, you know, tonight if I take my makeup off, I might use baby lotion. It's a cleanser. It doesn't have to be soap and water. So you're cleansing the skin. So yes, if you bath every day, then your steroid, and then half an hour later your moisturiser. You might find just little tweaking things like that will make a difference. And not stopping it the day it looks better. Think of the hidden eczema and then taper it out slowly, the steroids. So Elecon's a potent steroid, so you don't put that to the face, you don't put that to the sensitive areas, but there's so much information now, you know, we always say hit hard, get out of trouble, and then pull back, rather than pussyfoot around. So it's your quantities in the early, and quite often I've had a child come to me, and maybe the parents have been given 30 grams of Elecon, and that's lasted them 2 months because they're frightened to use them. So I might say, well, look, let's go for something milder that we can quite happily use quite generously and get your child's skin out of trouble. And then you know you're using the safest steroids. So don't be frightened of the steroids, respect them, but learn how to use them properly. Obviously, don't use Elecon to the sensitive areas. But, you know, sometimes my consultant, as I say, he'd like Humavate and 500 gram pump dispensers because it can, then parents haven't got to worry about what they're using. No, it's an immunomodulator, so it's, it replaces a steroid, it dampens down the child's exaggerated immunological response. It's not very good for getting the skin out of trouble, but it's very good for keeping the skin out of trouble. So if I find that when I try to cut down the steroids, it all flares back up, and I've sort of done another 3 weeks just in case they were brewing a cold or something like that, and it happens again and again, then I will switch them over to Protopic. You've got 2 types of Protopic, children's and adults. If I think they've needed a lot of steroid, then it's obviously that their eczema is challenging, so I will go straight for the adult Protopic to maintain control and then pull it back slowly. Yeah, and that's fine. That sounds really sensible. Yeah, my pleasure.
One more question, yeah?
Oh, sorry.
Is it true about the 7-year cycle of eczema? So, like, is that now more information about that? I was, you know, about it, and I'm just wondering because my daughter definitely has grown out of it, and then she's had moments where
I think rather than say a 7-year cycle, I'd say that eczema peaks in the younger years and tends to taper out, and then at a later stage, as I say, asthma becomes more of an issue. It would be lovely if it automatically came under control at the age of 7, but what I will say is the bulk of my children are young, but it doesn't automatically get better. A lot of it is how aggressively and how much control you have over the eczema in the younger years. Then you've got a better long-term prognosis, so you're more likely to see the eczema coming under control and petering out as the child gets older. But that doesn't mean that we ever say to parents, well, yes, you can ignore your child's wretched eczema, let them carry on sleeping, you know, not sleeping at night or things like that, knowing that it's going to get better when they're 7. We say no.
What about later in like teenage years, kind of as they get older?
Theoretically, if you've had a child who's got eczema as a child, they've got an increased risk of having problems at a later stage. And if I've got a child who's had really bad eczema as a youngster, I would be advising caution about them doing jobs using a lot of chemicals, hairdressing, nursing and things like that, because they've still got that tendency to the barrier function problem with the skin, so they might be more prone to having other issues, contact dermatitis at a later stage. Does that make sense? Yeah. I can't. Yeah, clothing. Yeah, so cotton clothing is the best. Higher percentage of cotton that you can get. The other thing is we tend to say to keep away from the nylons as much as you can, and wool, so cotton clothing. I often have seen little ones and they've had this lovely band of eczema around their forehead, and it's sort of beautiful woolly hat that Nanny's made, but can she try, either lining it with cotton instead? So wool and cotton. The other thing is obviously trying to use non-biological washing powders, making sure that you're not leaving heavily perfumed conditioners on the fabric. There are a few household things that you can do, damp dusting and things like that. But what I do say is all of those little things will make a bit of a difference, which can all add up to make a difference. But the most important thing is moisturising. I often say to parents, rather than you vacuum the mattress and damp dust the bedroom every single day, with that half an hour, what's going to make a difference is getting the moisturiser on again.